Hello everyone, it's Elizabeth. Welcome to today's discussion on sickle cell disease. To facilitate this discussion, we are going to look at this disease by using a patient concept map. So we will basically use each letter of the word patient to break down things that are important for us to know. And we'll just take a look at that kind of as we go through this. So P in our word patient is going to bring us the patho. So the patho of sickle cell disease. Understanding the patho of a disease is really important because it kind of just helps us to understand why things happen in the body and how it affects different things. So, for instance, specifically for sickle cell disease, the red blood cells, which are very important cells in our body, they carry oxygen. We really need oxygen to survive. So the red blood cells are affected in this disease. And normal, healthy red blood cells kind of have this round appearance, a little bit concaved. But in patients that have sickle cell disease, they have a problem where their red blood cells kind of collapse and develop this sickle shape. And it is, named after the sickle. And that becomes an issue because these red blood cells that are sickled then kind of stick to each other and clump, and they can form an occlusion within a blood vessel, just like a clump of blood cells that are just not moving through like they should be. So, as you can imagine, that can create some issues. So, overall, this is a genetic problem. So, in the United States, this most commonly affects our African American patients. And, genetic problems are things that are passed down for generation to generation. And sometimes the parents don't understand that they have the underlying sickle cell trait that they could pass on, and that's kind of how this problem continues to occur. We will talk more about that in teaching specifically. Normal red blood cells without sickle cell disease, they are mostly comprised of hemoglobin A, versus adults with sickle cell disease, 40%, sometimes even more than that, but at least 40% of their red blood cells are made up of hemoglobin S. And this type of hemoglobin is more sensitive to low oxygen, and it causes the collapsing and sickling shape that occurs. And you can remember that because S, the patients that have sickle cell, they have more hemoglobin S. And patients with normal red blood cells, they have more hemoglobin A. The sickled cells, they're kind of rigid, and they don't pass through the vessel easily, and then they just get stuck together and they cause clumps, and this can occlude the blood from passing through the vessel. And it can cause what is called a vaso-occlusive event, which when we have a vaso-occlusive event, now the vessel is kind of blocked off from blood passing through there like it should be, all the elements that kind of pass through the blood vessel. And so this further potentiates hypoxia, which is a trigger for the cells to sickle. So it's like a problem that creates worsening of the problem. So when there is a patient that has a vaso-occlusive event, it can lead to ischemia of tissue. So this can lead to long-term organ damage. And areas that are commonly affected by vaso-occlusive events are the spleen. There's a lot of blood that passes in and out of the spleen. Similarly, the liver, lots of blood passing in and out of there, lots of little tiny vessels that can kind of get occluded and then have problems. The heart, the kidneys, the brain. So those are, really small blood vessels, lots of really small blood vessels that could get occluded. And then this could lead to ischemia of the tissue, which, that's not good if you've got ischemia in some of these big organs. And then the joints, this is a common place for patients to have a vaso-occlusive event, and they'll get pain in the joint, and it's a very common presentation in patients with sickle cell disease. And then also the retina, that one also, the eyes, they have the small blood vessels, and if the blood cells kind of get trapped in there, it can cause occlusion and ischemia and that type of thing. So we do have some things that we know have been identified to trigger a crisis in a patient. So it would be important for patients to avoid these things, right? So hypoxia, which could come along with an episode of pneumonia, or if the patient is somewhere that there are high altitudes and there's not enough oxygen available, that may lead to hypoxia. Another one is dehydration. So, dehydration can occur simply from just not drinking enough fluids, but could also occur from, drinking alcohol, taking diuretics. There's lots of things that could cause dehydration. So, that's something that can kind of make less blood volume present. Okay, so triggers. There are things that specifically trigger the sickling to occur. So, we really probably would suggest that patients avoid these things. But hypoxia is a big one. So these red blood cells are sensitive to low oxygen. And so if the patient has a low oxygen saturation, then that can cause these red blood cells to sickle. So it kind of potentiates the problem. So, oxygenation is a really big thing for these patients. So they really need to avoid hypoxia because that's just going to cause sickling to occur, and that's going to worsen their issue. And then dehydration, if you have less blood volume, so you have, your amount of blood that is within your vessel is less, then the sickled cells are going to cause more of an issue. So the patients really need to avoid becoming dehydrated. Infection, we don't want these patients to get sick. They're at risk. They're more at risk for getting sick. And being sick, having an infection can kind of trigger sickling as well. Venous stasis. So venous stasis is just whenever the blood is kind of just sitting in the vessel and it's not moving like it should be. So that can occur with like long periods of sitting, obesity that kind of leads to impaired ability for the blood to move as it should, especially from like the lower extremities. So they need to avoid that. We actually avoid patients that have sickle cell disease, avoid pregnancy, and that is because it can trigger sickling, and then this can lead to a whole bunch of problems because now we're worried about mom and fetus. Alcohol consumption, that can be a trigger. It can lead to dehydration, which further potentiates sickling. High altitudes, and that kind of goes back to the hypoxia. If we are in high altitudes, we may not have as much oxygen readily available, and this can lead to hypoxia. And then strenuous exercise, so patients that are really exercising heavily or doing a lot of activity, this could potentiate sickling. And then nicotine. Nicotine causes your blood vessels to kind of shut down a little bit, like constrict, causes your blood vessels to constrict. So if your blood vessel is smaller, and you have these clumping red blood cells trying to pass through there, that's an issue. So avoid smoking for these patients. And then once the precipitating condition is removed, the sickled cells return to normal. Okay, so this is good for perfusion. This increases perfusion. If a patient has a vaso-occlusive event, they're having a problem with perfusion because they can't pass those red blood cells through certain areas because they're kind of blocked off with clumped up red blood cells. And perfusion is kind of what keeps us from having the ischemia. We have actually blood and oxygen moving to the areas that they need to move through. And then once the precipitating condition is removed, some of the sickle cells do remain twisted, and then they're fragile, and then they're easily broken. So we have a much higher rate of red blood cell destruction in patients with sickle cell disease, and so this can lead to just a higher turnover of the red blood cells. And when red blood cells are destroyed, they release bilirubin, which then causes our patients to become jaundiced. So we will see jaundice in patients that have sickle cell often because they have a higher destruction of red blood cells. So hemoglobin S red blood cell, the patients that have hemoglobin S, which are the sickle cell patients, the average lifespan of their red blood cell is 10 to 20 days. That's not very long. Typically, the normal healthy red blood cell that's mostly comprised of hemoglobin A, that one's lifespan is 120 days. So, as you can imagine, it causes some issues. That buildup of jaundice, buildup of bilirubin, it can cause problems with the gallbladder. It can cause a lot of problems for your patient. So in summary, the patho of this disease, it is a genetic disease. It is a problem with the hemoglobin, too many hemoglobin S chains, making the red blood cells sticky, and the red blood cells are sensitive to low oxygen, which causes clumping and occlusion in the blood vessels, which can cause ischemia and tissue damage. And then there's early destruction of red blood cells. So then let's just move along here to assessment. The patient who has sickle cell disease, sickle cell disease is an underlying disease. So they have this problem, it's a chronic problem. But then they can have kind of like exacerbations of the problem. So we would call this like a sickle cell crisis. So, a lot of, chronic disease states, they will have just a stable form of the disease. So I have the disease, I know I have the disease, it kind of affects me in certain ways. But then there are episodes where I really have big problems. It's kind of exacerbated at that time. And so in this disease, sickle cell disease, we call that a sickle cell crisis. And patients who are in crisis are going to have pain at the site of the reduced perfusion. So sickle cell is an extremely painful disease, okay? And patients that have sickle cell disease are often not treated adequately for their pain. And there's a lot of data that just kind of suggests that maybe this is like a racial disparity because most of these patients are African American patients. So it's just super important to adequately treat patients' pain who have sickle cell disease because it is an extremely painful disease. So if they're having reduced perfusion, as you can imagine, that would cause pain. So if they're having a vaso-occlusive event in their joints, they're going to have joint pain. So, it just kind of depends on where it's happening in the body, where they'll have the pain. There's not really like a specific test that says, oh, they're in crisis right now. So we just kind of have to just take their word for it. Like when they're having pain, that's probably suggestive of a crisis. So a chronic underlying problem that these patients are going to have is anemia, because remember we said that red blood cell is destroyed much earlier, so we're not going to have as many red blood cells as a patient who doesn't have sickle cell disease. So if we have sickle cell disease, we are going to know that this patient is probably going to have a chronic underlying anemia, which is a decreased hemoglobin level. And red blood cells, hemoglobin, hematocrit, kind of across the board, those are all just going to be decreased. So sometimes these patients will have that, they'll have some anemia, and it doesn't really cause them symptoms because they've chronically lived with this problem. Or sometimes, if it gets to be severe enough, it's going to cause symptoms. And that's something we would take into consideration on if we were going to decide, what we were going to do, how we were going to treat it, is if they're having symptoms or not. But specifically, anemia, symptoms associated with anemia are shortness of air. So, red blood cells carry oxygen. So if we don't have as many red blood cells as we should, it'd be expected that we might feel short of breath. and then fatigue and pallor. So pallor is just pale skin. We have pale skin because we don't have as many red blood cells as what we typically do. So those are symptoms of anemia, and your patient with sickle cell disease is probably going to have chronic anemia, but they may have times where they have more severe anemia and are having more symptoms. In a patient who is having a vaso-occlusive event, especially of like a joint, they may have a decreased peripheral pulse, decreased capillary refill time, and decreased temperature of that extremity. Okay, and that's telling us that they are having a decrease in perfusion, which is a big issue. We need to get that addressed. And like I said, these patients may have jaundice because these red blood cells are being destroyed early, and this releases bilirubin and causes our patients to become jaundice. So, in thinking about this, in a patient who has, darker skin, our African American patients, we need to think about how we assess jaundice in a patient who has darker skin. Also, how we assess pallor in a patient who has darker skin. And then another thing, physical exam finding that you may see in patients who have sickle cell disease are they may have chronic leg ulcers due to just chronically having poor perfusion. All right, this brings us over to the T in patient, which is tests. So electrophoresis is where the pathologist looks in the microscope at the distribution of types of hemoglobin within the red blood cells. So this is a special test, and it measures the percentage of hemoglobin. So if a patient has greater than 40% of hemoglobin S, like we discussed earlier, that is a diagnostic feature for sickle cell disease. And then, like I said, they have like a chronic underlying illness. So these would be considered as expected abnormal lab results. They're going to probably have some chronic anemia. They're going to have chronic kidney disease a lot of times because of those blood vessels within the kidneys. They have like microvascular damage that's chronic. And so this kind of creates an underlying chronic kidney disease. They may have an increased reticulocyte count. Okay, reticulocytes are little teeny tiny immature red blood cells. So these are like the baby red blood cells, and they are produced, at a pretty rapid rate in somebody who has anemia. So if I have anemia, my body's going to produce more immature red blood cells. Okay, so that's what a reticulocyte is. And in patients that have sickle cell disease as a chronic disease, they're going to likely have an increased reticulocyte count. And then the elevated bilirubin level, and that is as a result of rapid red blood cell destruction. We get more of the bilirubin released. So this will show up in their labs, elevated bilirubin. Oftentimes they have an elevated white blood cell count that is chronic, and this is due to chronic inflammation within the body. And, this is going to be mild. It's not going to be like 18,000 white blood cells. It's going to be like just a little bit higher than our normal average white blood cell count. And it's important to monitor these patients for infection. So white blood cell count's very important for these patients. And so just knowing that they may have a chronically mildly elevated white blood cell. Okay, this brings us to interventions. So as I said, these patients are going to have a chronic underlying disease, and then they may have episodes of crisis. So in patients that have a crisis, we are going to really aggressively manage pain. So opioids are commonly used in these patients. They may even be getting a drip, like a patient care controlled anesthesia, which we have it on here as a PCA. So they may have a PCA pump. And this is where the patient can determine on their own. They're going to have like continuous narcotics going through an IV from this PCA. A lot of times they'll have a continuous, smaller dose. And then they also will have the ability to push a button whenever they're having severe pain, so that will give them another bolus of the pain medication. And so morphine and hydromorphone, those are common drugs that we would use in a patient-controlled anesthesia pump, PCA pump. So they will usually be getting opioids, and then also, we want to treat them with other non-opioid options. So NSAIDs are a good option, so non-steroidal anti-inflammatory drugs, such as Toradol is an injectable option that they may get while they're in the hospital, or ibuprofen is another one. It's obviously not injectable, but there's several different types of NSAIDs. Now, NSAIDs, just keep in mind that NSAIDs can kind of be toxic to the kidneys. So if they have really bad kidney disease, they're probably not going to be getting NSAIDs. But if it's a younger patient or somebody who hasn't had a lot of complications, NSAIDs are a good option. And then we typically are going to get these patients on oxygen. So this is a problem with the red blood cell. So the underlying problem is a problem with the red blood cell. And if the red blood cell is collapsed, it's not going to be able to carry as much oxygen. So we really are probably going to give these patients oxygen. And then we said hypoxia triggers sickling. So another good reason, even if their oxygen saturation is normal, in these patients we may go ahead and still give them oxygen. And then we're going to hydrate them with normal saline. If we have more blood volume, these sticky red blood cells are going to be more easily able to move through the vessel. So normal saline is going to be really helpful. And they may get a pretty high dose of normal saline, kind of starting out to kind of really make sure that they're not dehydrated. And as we discussed, dehydration is a trigger. So IV normal saline. And then we want to remove any constrictive clothing. So if I have something really tight wrapped around my extremity, then that's not going to help the blood kind of move through my vessels if things are just being physically pushed on from tight clothing. And, we've all seen, people with, the skinny jeans and, those can really kind of get tight around knees and things like that sometimes, especially if you have any swelling or anything. So, and then we're going to keep the extremities extended to promote circulation. So a lot of times when we think about, they've got a problem with a joint, we want to elevate it, well, that is not really what we're going to do here. We're going to try to keep that joint just straight, so that way, we're not restricting any blood vessels so that the blood cells can move through easily. So if we just keep it nice and straight, that's gonna be the best for this patient. Head of bed less than 30 degrees. So again, if we're elevating, we may be constricting some things. So we just want to keep things kind of flat. And then check the circulation of the extremities at least every hour. So that's just making sure that we have a good pulse past the point of like the vaso-occlusive crisis. So like if it was in an extremity, and that our capillary refill time is okay. And so every hour, that's, it's a pretty, if you've got other patients that you're taking care of, you got to make sure you're staying on top of that. And then doing a pulse oximetry of the fingers and the toes, and that's just going to give us more information on how much oxygen saturation we have of those extremities. And I already said we're going to be checking the peripheral pulses and the capillary refill. We're going to keep the room warm. If we get cold, our blood vessels can constrict a little bit, and if our blood vessel is more narrow, those blood cells that are kind of clumping together and sticking together are not going to be able to move through as easily. So we're going to want to keep the room nice and warm, and then we're going to apply heat to the affected area, and that's going to kind of help relax those blood vessels so more blood cells can move through. So that would be, avoiding ice. It's, I think typically when somebody has an injury or when somebody's having like a joint issue, we're like, elevate it, put ice on it, and that's not really going to help our sickle cell patient. It's just kind of a different approach. So then the patients that are needing prevention, or that are having their chronic illness and they're just needing some maintenance, we use some of these different medications. So I do kind of go into detail on that a little bit more down farther. So let's just look at this real quick. We're going to monitor for infection. And then ways that we can do that are to keep a close eye on our white blood cell counts. So like I said, they might have a mildly elevated white blood cell count chronically, but if that white blood cell count is really getting up there, we need to make sure that they don't have an underlying infection. We can also assess for infection by listening to the patient's lung sounds, checking them often for urinary symptoms, having any pain with urination, frequent urination, things like that, and then monitoring for fever. So specifically some of the medications, I talked about some of this a little bit, but pain medications, I'm going back to a crisis here, okay? Pain medications, some of these patients may have chronic pain, chronic underlying pain. So if you take somebody who takes opioids every single day for chronic pain, and you give them pain medication in the hospital, like IV dosages, it's probably not going to, the lower dosages probably aren't going to be as effective on them because they already have some tolerance built up to opioids versus a patient who is what we call opioid naive, meaning that they don't really get opioids on a regular basis. So if you give them a lower dosage of opioids, it's going to affect them more, So, we need to keep in mind that if the patient is taking chronic opioids, that they may have some opioid tolerance and they might require higher dosages of opioids. And then we talked about, kind of using NSAIDs in conjunction with narcotics or opioids, but, caution in patients that have chronic kidney disease. Hydration. Initial rates are often greater than 200 milliliters an hour for the first few hours, but then can be reduced to 125 an hour once hydration status has improved. I don't think you need to memorize that. It's just an idea of how much fluid they're really going to be getting. And then just further into these like maintenance medications. Hydroxyurea, this stimulates fetal hemoglobin production, okay? So it just is another type of hemoglobin that acts more like normal hemoglobin. So it just increases these circulating fetal hemoglobin in the red blood cells of the patients who have sickle cell disease, so maybe they'll have less sickling. And so this can increase gas exchange, decrease sickling, and I was really impressed with it improving gas exchange. Okay. So the risks associated with hydroxyurea. Long-term use can cause an increased risk for leukemia, okay? So obviously we don't want our patient to get leukemia, but how would I know if my patient had leukemia? So leukemia is cancer in the blood cells, and so our patient who has leukemia is going to have typically, they're going to have a really high white blood cell count. So in a patient who's taking hydroxyurea, we should probably be looking out for a really high white blood cell count. I mean, either way, if it's leukemia or infection, these are things we worry about in patients with sickle cell disease. So that's something to keep in mind. And then hydroxyurea is a teratogen, so it can cause birth defects. So we would definitely want to avoid that in pregnant women. And we already said maybe pregnancy isn't the best idea for a patient with sickle cell disease. This also suppresses the bone marrow, and our bone marrow produces our blood cells. So we need to routinely keep an eye on a CBC for these patients because we don't want too much suppression of their blood cell lines, white blood cells, red blood cells, platelets. Okay, and then another medication, and I definitely don't think you necessarily need to memorize a lot about these, but this is just an idea of other things that maybe are used to treat. I would say hydroxyurea is like the most commonly, maybe tested on or something you might see. Indari, this increased amino acid glutamate. So it basically decreases sickling rates and causes a longer red blood cell lifespan. And then crizanlizumab. So this ends in MAB, meaning it is a monoclonal antibody. So this binds to platelets to decrease clumping of red blood cells and prevent vaso-occlusive crisis. So this is a once monthly IV infusion. So just as you kind of go along and learn about different medications, a lot of these that end in MAB are infusions. Not all of them, but pretty common. Okay, so we were on I of our word patient. So now we're going to move over here to E, which is extreme, which is, the worst case scenario, like what's the worst thing that can happen to my patient that has sickle cell disease? So that is acute chest syndrome, okay? And this is associated with respiratory infection or fat embolism. And fat embolism, I would say most commonly we're going to hear about that in a patient who has a broken bone, especially a large bone, and that bone marrow is affected, and it releases some different substances that is just called a fat embolism. So that is what acute chest syndrome is associated with, okay? And symptoms are similar to pneumonia. So the patient has a cough, the patient has shortness of breath, the patient shows an infiltrate on their chest x-ray. So they may present with like chest pain, shortness of breath, cough. You may think that they have pneumonia. So pneumonia is taken very seriously in patients that have sickle cell disease, obviously, because it's an infection, it can have hypoxia, it can lead to dehydration, all these things we're worried about in sickle cell patients. But if they get this extreme form, which is called acute chest syndrome, then, it's actually a really high cause. It's like a leading cause of death in patients with sickle cell disease, because it can lead to respiratory failure and multi-organ dysfunction. Yeah. And then other extreme things that can kind of happen to patients that have sickle cell disease are priapism, which is a prolonged erection, and this just kind of occurs because that area gets occluded, and then we just kind of have this problem with priapism, and this can be a medical emergency, and they need to seek urgent care, probably emergent care. Okay, this brings us to N, nursing diagnosis. So ineffective tissue perfusion. So we talked about how if these areas are occluded, they are not being perfused. So we're having ineffective perfusion, which then of course leads to ischemia. And then acute pain due to poor tissue perfusion. Talked about how these patients are often in a lot of pain. And then potential for infection. They're commonly going to get infections, and we need to address that. So teaching. What are we going to teach these patients? Well, we need to teach them to avoid their triggers. And we talked about what some of the triggers are. Hypoxia, low oxygen saturation. We need to avoid that at all costs for these patients. Dehydration. So they can avoid dehydration by drinking like 3 to 4 liters of fluid a day. So they're going to want to increase fluid intake to 3 to 4 liters a day. All right, so to avoid that dehydration. They're going to avoid infection. And how can they avoid getting an infection? Well, they can get their vaccines, okay? Pneumonia, flu, and COVID vaccines are recommended for patients with sickle cell disease. And then wash your hands, you filthy animal, right? We want them to wash their hands, avoid large crowds, all those things that we tell patients to kind of prevent getting an infection. Avoid venous stasis. So, don't sit in one spot for 3 days. If you're on an airplane, get up and walk around every hour or so. If you go on a trip, get up and walk around, those kind of things. Pregnancy. We want to avoid triggers, so probably avoid pregnancy. And, there's lots of ways to do that. Contraception, condoms, oral birth control pills, whatever the healthcare provider sees fit for that patient. Avoid alcohol consumption. Okay, we talked about how this can lead to dehydration, which can cause problems for patients with sickle cell disease. Avoid high altitudes. There's less oxygen, free oxygen in the air whenever you're in somewhere that has a high altitude. So probably not the best place for somebody with sickle cell to be. Avoid strenuous exercise, so don't go out and run a marathon if you have sickle cell disease. We do usually recommend sickle cell patients exercise, right? We want them to stay healthy and stay fit, but we don't want them to overexert and that type of thing. And then nicotine. We talked about nicotine can kind of cause your blood vessels to constrict, and that is not a good plan for somebody who has sickle cell disease. So another thing is they are supposed to avoid airplanes that have unpressurized passenger cabins. Okay. And then notify the healthcare provider if they have sickle cell disease before they receive anesthesia. And they should speak with a genetic counselor prior to becoming sexually active. And so we're going to talk about how this kind of gets passed down here in a moment. When not having a crisis, low impact exercise is recommended. Okay, always avoid strenuous exercise. So this kind of lays out patients that have sickle cell disease and how they may pass that on. So for this issue, trait, so sickle cell trait is what is described when the patients got one abnormal gene, so it's only affecting one gene, so they still have the normal gene. Okay, so this father right here, he just has the trait. So he has one normal gene and one abnormal gene. So he doesn't actually have sickle cell disease. He's got the trait, so he doesn't have symptoms. Okay, he's asymptomatic, but he has one abnormal gene. So then, if he is to reproduce with mom here, who's normal, she has two normal genes, then half of the offspring are going to have normal genes, and half of them are going to have the sickle cell trait. So they will be asymptomatic, but they will have the trait. Okay? So this is not really a huge deal, right? They have the trait, but they're not having any symptoms. It's not really affecting their day-to-day. Like, they probably don't even, most of the time, they're not even going to know they have it. Okay? The issue lies here whenever this person who has the trait then also has reproduction with somebody who also has the trait. So now two of these people are asymptomatic, may not even know they carry the trait. So I do think this is like on the newborn screening now in the United States, but we have lots of people that come that are from other countries. So, I may have been tested and know that I have the trait, but I'm, not necessarily asking or knowing that my partner has the trait. So if two people that have the trait reproduce, they're going to have, two offspring that are going to get the abnormal, one abnormal and one normal, one abnormal and one normal gene. Okay? Because these people have one normal and one abnormal gene. But one of their children is going to inherit the abnormal gene from each parent. Okay? And then one will inherit the normal gene from each one. It's kind of convoluted. But, just keep in mind that the person who's pink here has one normal and one abnormal gene. And so their kids are going to get one from each of them, and they may get the normal or the abnormal. So this is typically how it's going to happen. Obviously, they could have two in a row that have nothing. But just, statistically, this is what's most likely to happen. So then, if we have the dad that has sickle cell disease and the mom that has both normal genes, each kid is just going to get one abnormal and one normal. One abnormal, one normal, so they're all going to have the trait. Okay? But then if we have somebody who has sickle cell disease that reproduces with somebody who has the trait, two of these kiddos are going to have the disease, two of them are going to have the trait. And then, you know, worst case scenario here, 2 people that have sickle cell disease reproduce. Every one of those kids, they're going to get an abnormal and an abnormal gene from each parent. So they're going to all have sickle cell disease. So hopefully that kind of was easy to understand. All right, so we've got sickle cell disease, patient concept map. Thanks for joining me.